evening, everybody. My name is John Wilkes. I have the privilege of being Chief Executive of the Institute of Health and Social Care Management, and I'm absolutely thrilled this evening to welcome Steve Sawyer. Steve is Managing Director of Access Health Support and Care, and if I'm right here, Steve's going to be focusing on the digital potential, what the care journey could look like. We're going to be looking at untapped potential in existing technology and opportunities to innovate through the social care pathway. I'm so thrilled we've got absolute focus on social care this evening. Without further ado, Steve, I'm going to hand over to you. Thank you very much indeed.
Thank you very much, John. Okay, so yeah, that's exactly the agenda I received as well. So we're off to a good start. That's good. Yes, this is a focus on social care. It actually, of course, will encompass health within that. But this is the total care pathway. As you say, some of this will be what could it look like? Some of it is going to be what does it look like? And what are some of the latest innovations that we are seeing as well? Now, we've got quite a mixed audience, as I understand it, on here today from right across the health and social care spectrum. So I'm going to try and cover across the bat. These are my views, our ideas, within the organization, and hopefully there'll be at least a little something in here for everybody. I'm sure I will inadvertently probably say something contentious, as we all have our opinions, and those of us that work in health and social care, as we all do, care very passionately about it. So
I wouldn't worry about being contentious at all, Steve. The worst guests are those who choose not to be. So looking forward to
I'm sure I'll be inadvertently contentious if I am at all. So thank you very much. As you said, my name is Steve Sawyer. I'm Managing Director of Access Health Support and Care. I've been part of this division, launched this division back in 2013, 2014, although the constituent parts of the division go back for much longer than that. So let me give you a little bit of an overview. By the way, I have tried wherever possible throughout this to avoid things like product names. We are a software company. We have lots of solutions in this space. Today is not an advert. I'm not taking it as an advert. I have, wherever possible, expunged product names, that sort of thing in there. If you're interested, you can have a look afterwards. There are a couple of videos in here where unfortunately I couldn't remove product names. So please just, let them pass by. I'm very much of the belief that this is talking about the topic and not about access. But just to give you a bit of context, first of all, as to who we are, Access Group, we are one of the largest software companies headquartered in the UK. We've got about 7,000 staff, and we work with about 80,000 customers. A broad range of technology within that. Importantly, we work within a set of key verticals, key markets where we have specialisms, whether that's legal or hospitality or education or not-for-profit, or in my case, Access Health Support and Care. I'm sure, wittingly or unwittingly, you will already use some of our services somewhere, if only because you're booking a restaurant or a venue or something for Christmas. You're likely to be using something like Res Diary or Design My Night or something like that. That's us as well. So it's quite a broad spectrum of things. Let's get to the important part from my perspective here, which is health support and care. This is really just to give you an idea, if you don't know who we are, of sort of the spread of what we do and where we're coming from when we talk about this. There's about 850 individuals in the division who are specialised in and focus on health support and care. When I say support there, that typically means local authorities, and we say support because it is, yes, it's care, it is also partly education, it's SEND, it's a whole range of things that sit within that. We are, as far as we believe, unique in delivering digital transformation solutions right across health support and care. So it's across that broad spectrum. And the reason we do that, it's been a deliberate strategy on our part. When we launched the division back in 2014, I had a view then around how do we make health support and care easier? How do we make it more integrated? What's the way that you can improve the system? And I know we all want to improve the system because there's some fundamental issues within there. Happily for me, we did various things bringing organizations and solutions together. And at the same time, the sort of political landscape, the will towards integrated care has gone in the same direction. partly, of course, accelerated by COVID. And if there's any good thing that came out of that, and I'm sure there's probably actually quite a few, one of them is the increased funding and focus on digitization. And the other part of it is the increased profile and focus on social care and care, sort of rebalancing that agenda between health and care. And I think that's a really important thing. So just to give you an idea of our spread here, we work with some 45 NHS trusts. There's about 150,000 clinicians use our EPR systems. There's 14 NHS trusts who are using us for virtual wards. We work with about 200 local authorities, so most of the local authorities across the UK in some form or another, whether that's their social care case management or it's brokerage or it's monitoring and commissioning, you know, a whole range of things within that. 48% of councils in England use our provider assessment and market management solutions for understanding the local care market. There's about 600,000 people who receive care in the UK that's actually supported by our systems on the social care side, about 25% of all social care hours. Around 350,000 care workers are rostered using our solutions. And then we've got about 60,000 individuals who are receiving tech-enabled care supported services, 30,000 wearable devices out there, and well over or approaching 750 million social prescribing visits. So it's a broad spectrum of stuff that's going on, which is what sort of gives us our insight into how might we join these things up and how might the care journey look in the future. The spread of organisations that we work with is very, very broad. It is, as I said, it ranges from NHS trusts through local authorities, through the third sector, charitable organisations, and then on the care side, we work with startup, mum and pop shop, home care providers, right through to the national networks, from domiciliary care through residential, end of life, supported, complex, LD, you name it. It really is a very, very broad spectrum within all of that. So I'm going to try and cover lots and lots of bases today, which is going to be pretty tricky. But that just gives you a little bit of an idea of who we are and what we do, where we come from, right? So digital potential, what the care journey could look like. I'm going to cover off a few things here. We're going to talk about the care continuum as we see it, what we mean by that and where we think that's going. I'm going to talk a little bit about the operating environment for health and care. There will be no surprises in all of that. That's the slight bemoaning isn't stuff difficult section of it. Before we get into the actually what are people doing, what are systems out there coming along that make that better. So that's kind of the flow that we will go through here. So the care continuum. We all know health, social care in the UK is a complex world and a complex journey. And we are all on that journey at some point in our lives. And certainly all of our family members are on that journey at some point in our lives. And we weave in and out of that health and care continuum. And it goes through a whole series of stages. And this is kind of the important thing, that there are multiple stages, there are multiple components involved in all of this. And for me, the improvement in the care journey is how you remove the elbows out of this. How do you move the bump strips that sit between each of these parts of the journey to make it smoother? And that sort of ranges from self-care, so at the beginning of the continuum, somebody looking after themselves, engaging in self-care, managing their own health, making lifestyle choices, sometimes the wrong lifestyle choices, which means other interventions are needed, other preventative measures are needed, through professional care. So as those health conditions evolve, people seeking out professional care, whether that's going to their GP or going to specialists or hospitals, etc., and then all of the diagnosis, treatment, management of health issues, etc. We've got, of course, home-based care within this, and that might be, it might be nursing, it might be short-term rehabilitation, it might be long-term home care and support on that, much of which, of course, is local authority commissioned social care, much of which is actually provided by private care providers and third sector. So we've got some complexities that all sit around that. Then there are community services, which are a key part of the care journey, the care continuum. And we're thinking here really of things around social support, CIC's mental health programs, community health centres, clubs, charities, all of those things that support in the community, probably in, dare I say, a lower cost setting, a more charitable setting, something which is not pulling on the NHS purse or central government purse out there as well, but which are big social determinants of health and wellness. And then, of course, you've got the eventual institutionalized. That's very hard to say at the end of a Monday. Institutionalization, by which I'm talking here, longer-term care facilities, care homes, hospices, assisted living, etc., and all of the complex needs that can go with all of that. Now, all of that provides an opportunity, if we think of it as a continuum, if we think of it as a journey that somebody weaves backwards and forwards upon, all of that does provide the opportunity for coordination, collaboration, a continuity of service, and the opportunity to remove some of that fragmentation that goes on. The only thing is, and technology is going to play a huge role in that, it already is. The only thing is it's not really there at the moment, or it's there in pockets. So really, this is all about what are the thoughts, what are the things that can be implemented along a vision of the care continuum that's going to start smoothing the way and eventually leading to that big joined up system. So if we think about what does it look like right now for local authorities, social care, for healthcare and for care providers, let's have a little think of that for a moment. Oh, now my laptop's frozen. That's not very helpful. There we go. So let's just have a little think around these for now. For local authorities, of course, I don't know whether we have anyone from local authorities on here, whether we've got any commissioners, etc. on here. We may do. Local authorities, of course, are focused on managing council-run services to support their residents, whatever those may be. And within that, within the care setting, it's all about establishing needs and providing or commissioning and then monitoring care provision and managing all of the associated finance to all of that. I'm boiling down a very complex area into a single sentence there. And then, of course, meeting all the legislative and regulatory requirements and increasing regulatory requirements within that. And within that setting, of course, the operating environment is one of increasing demand, budget constraints, staffing challenges, and greater scrutiny. Happy days. All four things that, you know, do not make anyone's life easier. That's what it is. We all know that's the environment that we're operating in. When we look to healthcare, of course, or healthcare NHS care within this, in this setting, we're looking at delivering the right healthcare or medical intervention at the right time to the right people. That's no small ask, because the wrong people turn up and they're looking for the wrong things, and it's all at the wrong time and everybody comes at the same time. All of that difficulty that sits within all of that. And because of all that difficulty, you've also then got to ensure the efficient use of limited resources, whether that's people or whether that's beds or whether it's medications and equipment or whatever it might be. There's a limited pool of resources there. And you've got to do that whilst operating a safe and sustainable service, again, in a regulated environment with exactly the same increasing demand, budget constraints, staffing challenges, all of that stuff as well. No easy ask. And then for the care providers, who are often kind of forgotten in this equation, I think sometimes forgotten because they're sort of on the other side of the fence, where with many being private providers, they are effectively being paid to provide the care out of the local government purse. But of course, they are an absolute intrinsic part of our care continuum. They're an intrinsic part of how care is provided and how health is provided and how we avoid people getting into a health setting in the first place, because boy, is it better that somebody stays in their own home bed or in a £200 a night bed rather than a £2,000 a night bed. That's got to be the aim here. So for the care providers, when I think about all of the complexity and variety that sits in care provision, ultimately, it's about getting the right person in the right place at the right time, whether that's out in somebody's home or in the community, or if it's in a care home, and allowing that individual to deliver the right care for the right individual against the right processes, and do that in a safe and sustainable service. And sustainable is an important word here, because if these care providers are not able to be sustainable, and by the way, that often means profit making, because these are private businesses, and if you aren't making any profit in there at all, that doesn't work. So, we have to accept that. That's a challenging area as well. And of course, they also are subject to increasing demand and budget constraints and staffing challenges and greater scrutiny. So there's a happy thought for a Monday afternoon. We've set off there. There's laying it all out for us. All of that, when I think of it, is really about capacity, cost, complexity, and compliance. Those are the enemies. Those are the things we're trying to deal with. For me, when I think about capacity, there is so much narrative about recruitment. There is so much narrative about lack of staff, and absolutely it's true. But I'm also a firm believer that there is masses of wasted capacity. There is inefficiency in rostering. There is inefficiency in commissioning. There is inefficiency in people simply picking up the phone to try and find out if there's a bed out there somewhere, rather than using a system that could tell them where the bed is and what the right price for it is, and how quickly they could discharge somebody out to it, and how to pass the medical record over so that that poor individual that eventually ends up in that bed 2-3 nights or a week later than they should have done actually has their meds with them. All of those things, get that right, you improve capacity. So I think that's a big part of it. So what we've got at the moment is a situation where capacity, cost, complexity, compliance, they are all exacerbated by siloed services and siloed systems. That might be an EPR that's disconnected from anything else. That might be a social care record that it has no connection at all to the actual care delivery records. That might be somebody out there that's doing care delivery who does not get the detail from the social care record. It's all got to be rekeyed in. Worse still, actually, they're going to sit down with some individual who's perhaps a little frail, who needs support, and probably their daughter, it's usually their daughter, sitting down, and they're going to ask them to tell them the story all over again, where they've already told the social worker the story, and the GP the story, and A&E the story when mum had a fall, and now they're doing it all over again. Goodness me, could not this be joined up? It needs to be joined up. That's the sort of environment that we're talking about here. All of that, we know, leads to a whole set of challenges. It's that lack of consistent view. It's wasted time and effort. It's duplication and errors. It's difficulty reporting. It's poor purchasing decisions. That occurs. We know there's poor purchasing decisions. It's trying to put all of the effort in one place where actually there's somebody that could provide somewhere else. It is a limited view of capacity. It's things like slow discharge, etc. And if we think of all of those reports that are out there, you know, ADAS in 2022 reported nearly 300,000 people waiting for an assessment of their needs, and 600 people joining that list daily, and a further 37,000 people waiting for a package of care, and 210,000 people waiting for theirs to be reviewed. We have to create some capacity here. There has to be something that can work. NHS Confed found that only 4 out of 10 patients were able to leave hospital when they were due to leave, because they couldn't get out into the social care support that they needed. There's stat after stat after stat that show this is a really difficult situation. When we come onto the other side of what does that actually mean for the care providers themselves, well, there's all sorts of impacts that this lack of joined upness creates there as well. That limited or no view of healthcare information, inefficient commissioning, inefficient payment. They don't receive their monies. You know, this is a tough place to be if you haven't got a flow through of cash on it. Poor capacity usage. This is a really interesting one we see in the data. Whether that's not filling empty beds or peak and trough rotas. What do I mean by that? I mean inefficient and pattern-based commissioning, where a commissioner says, we need some services for Mary. Forgive me if there are any Marys on here. Mary is my generic name I use for somebody who needs some support, where I'm going to commission a contract for Mary, and I'm going to just say, because this is what I always say, she needs waking up for breakfast at 8 a.m, she needs a lunch call at 12, and she needs a dinner call at 5. And you know what? Every single blooming care package commissions the same darn thing. And these poor care providers have peaks at breakfast, lunch and dinner where their staff are overrun, and they have troughs in between time where they have got staff available, where there is capacity, but the commissioning doesn't work with it. And actually, what hasn't been done is nobody's then done a review or looked at what is the real world usage here. Does Mary actually get up at 8? Is Mary happier getting up at 6 in the morning and having breakfast then? Or does she want to lie in till 10? If she's anything like my grandparents, it's 6 in the morning, because somehow you seem to lose the ability to sleep, it seems. Or needing sleep. I could do with needing less sleep. I need more sleep, I think, at the moment. But anyway, so that's sort of the intelligence that we need around this that will help. What we do know, again, from this is from Care England, 82% of social care providers in 2022 were either in deficit or had experienced a decrease in their surplus. And a third of providers and nearly half of small providers, so those with less than 250 carers, had considered exiting the market in 2022. And certainly our data, we work with about 10,000 registered care providers, our data is seeing care providers going out of business and giving contracts back on it, which doesn't support anyone. This is a really challenged place. So there has to be some things we can do here. Now, interestingly, everything I've talked about so far has actually been operational. Very little of what I've said has been about the individual. And that has to be wrong, because all of this at the end of the day is about the individual that we're all trying to support, or the individual that we all will be at some point. So I'm sure everybody on here has this aim of ensuring people have the chance to live longer, healthier, independent lives in their chosen place, whether that's their home, another home, wherever it may be, and to do so by providing sustainable, safe, and high quality integrated care. That's the aim that we sort of support, and I'm sure many of you do as well. So what's that vision for the care journey? Where do we see this going? What are the prerequisites to this? So first of all, I believe we've got to have this person-centered care with an holistic view of the individual, which is all about delivering the right intervention at the right time. And actually, earlier in the chain, can we avoid those acute situations? You know what? A lot of the time you absolutely can if you get in earlier, if you spot things earlier. It's going to require a transformation of health and care delivery with more focus on prevention and prediction through things like social prescribing, assistive technologies, predictive technologies with AI. I'm going to talk somewhat about those very shortly. It's going to require closer integration of health and social care. They are, equal sides of the same coin, and they need to be equal sides of the same coin. Because if we can get that right, you do create capacity, and we can get some focus on those limited resources. There's a wealth of data here. When I look at the amount of data that we hold, it is absolutely huge. If we can get alignment on that, it is the most obvious opportunity for machine learning and AI to drive improved outcomes. And I'm going to talk a little bit about where we're doing that at the moment. And all of this does require an evolution of an interconnected portfolio of solutions, whether that's from one provider like us or multiple providers. It's generally going to be multiple providers to deliver that high quality care. So I'm going to talk through some of these opportunities. I'm going to pick out some concrete examples so it isn't all just theory. I'm going to talk about digitalization, I'm going to talk about innovation, and I'm going to talk about integration. Right, so digitalization, what's already happening? When I first started out in this area, and I've been in healthcare and third sector for about 20 years, but when I really started focusing on software in health and care in kind of 2013 or so, a lot of this stuff really wasn't out there. It wasn't embedded. I'm really pleased to say now that a lot of these things are just sort of, these are the starter requirements for running a care organization or running a health and care business. And that's a great thing. So digitalization is absolutely on the way, again, driven by or accelerated by COVID. So care planning and rostering are absolutes out there now. I cannot imagine there are too many care providers that don't have some form of care planning and rostering solution. And that obviously drives efficient operations. It means you are more easily able to suitably staff, even if it is very hard to recruit and retain. There are compliance systems out there for really managing some of that regulatory burden, for doing your CQC mock inspections beforehand so that you know what you're going to get, so that you can evidence well. There are great medication management tools out there now with integration through to pharmacy so that actually you can make sure people have got their meds and you can manage either whether it's prompting or actually administering meds on there. There are, of course, recruitment tools and learning management tools for the care worker to ensure they've got the right training, the right work, the right pay, all of which helps to drive retention. There are carer and family apps now, which are really well embedded out there. So the carers actually can focus on delivering care, not on writing notes. Nobody wants to sit there writing notes. If you can log it at the point of care, that's much faster. It's much better quality notation. And actually that's information that then can be intelligently used. Case management, of course, case management is absolutely endemic within local government, albeit it needs to extend a little bit further across adult services into children's services, making sure we fold into SEND and all of those sorts of elements to it as well. And of course, there's increasing use of portals, citizen portals, family portals, and finance portals, which are going to be required to manage that heavy burden of understanding where somebody sits in the financials, and actually to support the wider care circle within that. One area that we are seeing increasingly coming up, which I think is quite an important area, is around the digitalization of procurement and commissioning. There's still lots and lots of areas. This is in the flow in the care journey. There's still lots of places we see where we have a social care record, for example, in a local authority. There's a mass of data has been collected on this individual. There's an assessment that says this person has some needs. We're gonna commission some care for them. And then an army of people sit there on the phones ringing around, say, can you take somebody? Can you take somebody? Can you take somebody? Terribly inefficient. It's not against contract management. You cannot necessarily see exactly who you have contracts with, what the shape of those contracts is, what the quality of that provider is, etc. So increasingly what we're seeing is the digitalization of procurement and commissioning through brokerage systems, whereby local authorities have a great flexible system where they can really manage the budgets within that, where you're contract managing, where your care providers actually can get their payments quickly and easily, which drives more care providers to want to be on the platform. So you have a wider market as a local authority, a wider market of care providers that you can go out to, drives competition, drives quality within that, and it drives that flow of money, which is great. It enables the social workers to spend more time with users, so we're freeing up resource in that way. And with the appropriate reporting with it, it means you get much better commissioning decisions. It means you've got much better arguments to get funding for your care provision, because you know in your area what your care requirements are going to be. So there's a lot of benefits in doing this. I'm going to give you an example here. Let me pull this one up here. What we see increasingly is organizations that are using procurement across the board. They're using this sort of piece to go straight from the social care record into saying, this is the level of care provision we require, purchasing and pushing that data out. That's the important thing. Can we get that flow through so there's a continuity of it? And increasingly, we're talking with ICBs where they're looking at using this system, these types of systems, to tie together referrals, case management, and procurement to really streamline into a single system, get that continuity. To give you the example of West Yorkshire, so West Yorkshire, where they have done this, they were able to reduce their time taken for fast track referrals by 35%, and they reduced the time taken for commissioning care by 35%. Got a KPI for referral and assessment, which they had a KPI target of 28 days or less, and they're now well below that as well. They've reduced invoices. They were producing 10,000 invoices a year, and they brought that down to under 100 invoices a year. You just got to scale out the savings within this and the quality of information. So much better reporting improvements, much better ability to answer FOI requests, formalization of contracts on there. Suppliers, so the care providers, not experiencing delays to their payments. Imagine all of the conversations that removes as well. So all of those things have helped to smooth the care journey. So this is stuff that's real world, that's out there at the moment that organizations are implementing. What about on the more sort of the other innovative side that's here? Well, let's talk social prescribing. I can only see about 3 or 4 people on my screen here. So I don't know whether we've got any social prescribers on here or anyone that's involved in this area. Forgive me, I'm gonna dumb down some of this slightly. I'm sure I won't get it exactly right. But social prescribing and the role that this plays in the care journey. I talked earlier on about where is the care journey going? Well, it has to be a focus on prevention. It's got to be a focus on getting better early care outcomes so we don't have to get into those expensive health settings. So that really is about helping people stay healthy, happy, independent for as long as possible, reducing the opportunity or the chance of those more serious situations arising in the first place. Now, social prescribing has been around for quite a while now. Happily, there are link workers across the board out there. But this is all really about how do you drive better efficiency through that. So those link workers, I don't know whether we've got any on here today, people that are working social prescribing, the challenges are rising demand, overstretched teams, inefficiencies in researching what is out there, what social prescriptions can they make, multiple pathways, and you've got to join up all these records. It's all the same inefficiencies. If you digitalize this, which many are doing, you can get some absolutely huge benefits associated to it. So social prescribing, for those that aren't clear, is a way of connecting individuals with non-clinical activities within their community via a link worker, which forestalls any health situations. We can get a better outcome and we don't need to do it in a health setting. We can do it in a care setting, and maybe actually we're holding off in going into other care support as well. So this is relying on that broader social network that's out there. And it's not just signposting, it's not just health coaching. This can come into physical activity, diet, nutrition, mental health, substance abuse, gambling addiction, all of those things which impact care and health requirements. So I'm going to use an example here. This is Mira. And in this little case study, like Mira is 67 years old. She lives in a socially deprived community. She's struggling with increased living costs. Her health conditions are being exacerbated by this. She's not got the heating on. She's not eating as well as she was. It's leading to mental health issues as well. She's socially isolated and potentially, therefore, is going to need a bigger social care package or may end up in a poor health outcome, which is going to be poor for her, bad for her, and of course, it's bad for the public purse as well, and it's more strain on the system. So the social prescribing journey, how does this improve that sort of the care journey? Well, in this example here, Mira goes to see her GP, or perhaps it's via her social worker, and we're doing this via the case management record. And directly out of those systems, the individual that she talks to, the GP or the social worker, says, you know what, you don't need a medical intervention, but there is support that's available to you. And so directly from that native system, from the social care record or from the clinical system, they're able to make a social prescription. That assessment is arranged, it pushes out to that link worker, and that link worker receives the referral safely and securely. It's tracked. This isn't about a conversation that Mira may or may not follow up on. This is somebody who's actually got hold of it and said, right, I'm going to get in touch with Mira and make sure we get a good outcome out of this. They meet with Mira, they discuss her needs, they get some baseline measurements, some scores, so we know what the outcomes are going to be here. A social prescription is provided, and the link worker in this instance is able to look up a directory of services to understand exactly what's available through third sector, through support networks, etc., around to create a plan, a broad-reaching plan that is going to support Mira in this case. Now, she follows that up with further visits, and by the way, those prescriptions that were given out, those social groups, those dependency groups, whoever they may be, they actually, again, they receive the referral within the system. They can track it, they can notify the link worker whether it's been followed up on or not. All of this, of course, is measurable back so that we know what was the, if you like, the cost avoidance associated with all of this. So we've got all of those follow-ups that take place in here. And because Mira engages with it, and because she's supported in engaging with it, remember, this is outside of your traditional social care, it's outside of your paid for care setting, it's outside of your health setting. Actually, Mira receives the financial advice and support she needs. She's got the cold weather payments that she was due to get. She's got some support socially within all of this. She is supported and empowered within her community. And actually, she's less likely to visit the surgery. She's less likely to ask for some more care support. Her anxiety is improved. We're going to get better health outcomes out of this, or rather not get into a health setting. So this kind of approach, which is an earlier stage, flows through on the care journey, digitalized and therefore traceable and therefore measurable from a financial perspective. And that's the important point, because somebody does have to pay for some of this somewhere. She's now, through this, been able to access financial support, efficiency grant, health conditions, all of these good things which make her life better and save on time elsewhere. Now, of course, that can be across lots and lots of different settings. These principles are across different settings. So it may be within a PCN, and often they may pay for some of these services. PCN is preventing admissions to hospital, or might be providing support alongside ongoing primary care. Let's say this is a mental health trust or specialist service. This can give the ability to safely discharge earlier, getting somebody out there into the community with support earlier, where we're freeing up beds, we're freeing up resources, and we've got a better independence for MIRA. Or it might be a local authority that just wishes to point through to debt and housing areas, so we're reducing pressures there. I'm going to give you an example. There's a little video here, and this is one where I say, forgive me for the fact that it does include some product names. I do generally try to avoid those in these kind of sessions. This is a case study where we've done integration between social prescribing and the EPR. So it's a mental health EPR, and this is that flow through from being in the mental health setting out into a social prescription setting. It also gives my voice a rest and you a break from my voice. Can you hear that, John? Just nod for me. Thank you.
In today's fast-paced world, mental health clinicians face the challenges of meeting not only the clinical needs of their patients, but also their social needs. This can be overwhelming, leaving clinicians with less time to focus on what they do best, addressing the clinical needs of their patients. Meet Sarah, a mental health clinician who understands the importance of providing comprehensive care to her patients. However, she encounters obstacles in connecting her patients to social interventions in the community. Sarah spends up to 2 hours every day trying to meet the social needs of her patients instead of focusing her time on her patients' clinical needs. This is where the Rio Elemental integration comes in. It's our comprehensive solution designed to streamline the process and empower mental health clinicians like Sarah. These top features of the Rio Elemental integration make it a game changer for mental health clinicians like Sarah. View the local services that have been prescribed by the social prescriber allows the clinician to get to know what services are in the area. See what interventions are having the biggest positive impact on a specific cohort of patients. The link worker can communicate with the Rio clinician. This keeps the clinician up to date with the patient's health and well-being progress in a more qualitative manner. Referrals are pre-populated with the client's data, reducing the admin time to make a referral. A digital referral pathway for patients in Rio to be referred to social prescribing. On the Rio platform, Sarah can utilize the Elemental integration to easily access patient profiles. Pre-populated patient information makes referrals to social prescribing projects outside of a clinical setting super easy, helping the patients to increase their mental health and well-being through attending community-based services. Sarah can check back in and track progress and scores from various health and well-being monitoring tools, allowing her to keep up to date with the patient's progress in a more qualitative manner. At any time during the referral to social prescribing, the link worker can send notes back to Sarah, updating her on any relevant information. Sarah is also able to see what her patient is attending and how many attendances. Sarah says, the Rio Elemental integration has transformed my workflow. I can now focus on delivering the best clinical care for my patients while knowing that their social needs are being addressed. With the Rio Elemental integration, Sarah and her team have been able to achieve their goals of providing comprehensive care and improving patient outcomes. The Rio Elemental integration gives care organisations a software solution that streamlines processes, enhances communication, and enables them to deliver exceptional care. Discover the power of the Rio Elemental integration today and revolutionize.
I'll stop that there before it gets the proper advert at the end. So I think it's just a great example of that intersection of health and social care and bringing the records together to get a better outcome and create capacity within the system. I'm not going to read through all of these for the sake of time. The great thing is, and John, I'll send you this updated deck and very happy for you to share around. This really is very measurable stuff as well. And that's really important, of course, to understand, does it actually work? Is it really making a difference to services, to care services, to health services, and to individuals? So let's use another example here. And this is something that's really gaining lots of traction, is really very, very exciting out there. And this is around technology-enabled care, the next generation of technology-enabled care, and how that can improve the care journey. And what this really is about is using the analog to digital switchover, which is taking place at the moment, runs through 2025, which is sort of forcing the switchover of social alarms, using that as a catalyst to drive broader systems which deliver preventative and predictive care, which might be the first stage before somebody receives a greater level of care, or might be a supplemental to the care that they receive, or might be an ongoing measure which lets you flex and understand how much care somebody needs on an ongoing basis. So to give you an idea, this is using, sort of replacing those analog social alarms that are out there with digital alarms, and then adding in home sensors to that as well. So we can start building up a picture of somebody's daily living routines in a non-intrusive way. I'm not talking cameras here, and I'm not talking listening devices. We're talking non-intrusive, understanding how somebody might be moving around their home or what they're doing, and augmenting that with wearables as well to help support independence. And what we're doing here, and what we're increasingly seeing, is using that sort of technology to automatically build up patterns of daily living. So these are learning systems that understand somebody's daily living patterns, and then using AI and machine learning to spot those variations and those changes in the pattern, and to notify you of that occurring, because that may well be a precursor to a health risk. It may well be suddenly we can spot that somebody is not drinking as much as they were, they're getting up and going to the toilet a lot in the night, we've probably got a UTI on the way. It's that kind of, I know that's the example everyone always uses, but it's the simplest one to sort of explain. Or perhaps we've got somebody with degrading dementia, with an increasing dementia, and we're worried about, how often is the front door opened, and is it opened after 10 a.m. and is it left open? All of that kind of stuff, all of which may well require some sort of intervention. And then you're looking at saying, well, how do you then integrate that into care plans, care activities, or perhaps social needs assessment to understand what should we be commissioning for an individual and when should we be commissioning, so we are getting the right care at the right time and the right level that's needed. And all of that really is about ensuring that right level of support, being able to flex it up and down based on the evidence that's needed, delivering preventative analytics so we can predict some health risks and intervene at the right points or not if that individual is doing great, and supporting the care circle. So increasingly what you see here is driving and supporting independence by engaging the family to a much greater degree in understanding how is the individual doing. Do they need some more support themselves as well? I'm going to run a little video here which very much focuses on that care circle and the family role in helping that care journey. So I'm going to play another little video for you. Example here is Andy and his mother. So again, the focus there really is on preventative and getting ahead of issues to smooth that care journey. And that means for the individual, they've got confidence, they feel supported, it's maintains that independence for family and friends, they've got positive reassurance, they've got alerts, they know there's a safety net there. For the healthcare side of things, this can avoid hospital admissions or enable quicker hospital discharge if we're putting people out into the community knowing that we can monitor them in this way, or indeed it might well get somebody into hospital sooner before they really get into a bad way. Another great use of this kind of technology associated to it as well. It provides lots of detail for social care, for improved assessments, improved understanding when you join up the data of, okay, what are the meds somebody's got, what is the interaction we're having with them, and then what's their real world living pattern outside of that. If you triangulate all three of those, you can give a much better service and get much better outcomes. And actually, for care service providers, this is one to create capacity as well. It's another way of interacting with the people that you are looking after. It can enable flexible levels of care that you're going to provide. And dare I even say, for some care providers, it's actually another digital service, a consumer-focused add-on that can help support them financially as well. So there's lots and lots of great positivities that we are seeing already coming out of these approaches and the difference that it can make. And then the last one, and I have got a video, but I'm just watching timing, so I'm not going to play this video. Virtual wards, lots and lots of press around virtual wards. Now, virtual wards, of course, is not a panacea. It is another way of bringing together all of this data, bringing together what is traditionally care gathered data in the home or in another setting, and being able to review that in a clinical setting to work out, do we need this person back in or not? Or when should they come in? Again, creating capacity. And if you imagine, if we look at those things I've just talked about there, around tying records together, around in-home monitoring, around the ability to take automated News 2 scores, for example, assessments in the home, all of these things can support within a virtual ward setting, but it is broader than just simply in-home monitoring. It is about tying together the social care record, the medical record, etc. within all of that. So for time, I shan't play this video. I'm going to crack on past it. Right. There are lots and lots of great evidenced outcomes from these things. So again, we'll share this afterwards so you can read these at your leisure. We know these are making a difference. We know that this is improving the overall care journey. The final one I'm going to talk to then is the care continuum. So how do you sum all of this up? What do we believe in? What is the vision we're going for here? It is really to create that single view of the person throughout their life, as I said, through that care continuum, and you step through that sort of journey and go backwards and forwards amongst it. So it's about getting a single view of that person throughout that journey, throughout that continuum, making sure that it's person-centered, it's interconnected, it's seamless, because doing all of that saves the administration, it saves the errors, it saves the gaps in service, all of those things which actually cause inefficiency, wastage, whether that's financial wastage, resource wastage, capacity wastage. There's lots of opportunity throughout all of this to improve that and to deliver better outcomes for people. And that might be by unifying your patient records, your commissioning, your compliance, your case management, all of those things that we've talked about. Just to give you a couple of examples here, I'm going to whip through these. At the moment, you may well have your electronic patient record and your share care record, and that's got details of the individual. And ideally, that's flowing out to your digital home and remote support that we've talked about, or out to your commissioning. But of course, more often right now, it's actually a point-to-point web that takes place. Whereas really, what it needs to be is all about and centered through the individual. That's the common record that we're driving for, that we believe needs to be at the heart of all of this. Again, another example, you're flowing out to social care. I just talked about social care and the digital home and reporting support, and tying that together with your digital care planning and of course all of the analytics that come out of it. But again, right now, it's a web of point-to-point solutions. And what we really need to do is start centering that again around the individual. That's the sort of the vision and the place that we're working towards, and I think probably everyone is sort of working towards, and is after all kind of the ICB drive. So tying together all of that means you can then take advantage of all of these digitalized solutions that are out there, whether it's those social care systems, financial assessments and support, youth services, digital care planning, workforce management, medication management, policies and procedures, compliance, digital, all of these are digital systems that are out there at the moment that are providing benefit. I've talked about quite a few of them. Tying those together is going to be the thing that really frees up the system and improves that care journey. So to sum all of that, and I've kind of said it there already, that integrated system across the care continuum, I believe, is going to help solve the problems of capacity, cost, and complexity. And in part, that is all about focusing on prevention at home. It's about pushing out into lower cost settings and ensuring resources are deployed to the right person, the right place at the right time. That, by the way, for me, means there needs to be much greater focus on care and social care, and the spend in the pound needs to be a lot more at that end than on the NHS end, because if we can spend it there and save people ending up in the NHS, then we save a lot more money anyway on that setting. And part of the piece, I wrote an article very recently, I think it was in the Caring Times, about the need to balance ICBs and make sure there is a genuine voice on there for social care and care providers, because it is about balancing the two sides of NHS, of health and care. If we get a stronger care voice, we will get earlier interventions, we will get lower cost interventions, and we'll create the capacity that's needed. There we go. I've only left us 5 minutes, I'm afraid, John. We can all talk on these things for hours, I'm sure.
Well, it was very comprehensive, Steve. Goodness me, there's a lot of detail there. And I can see we've got quite a few students from Arden on the call as well, which is always great to have them along, and numerous supporters in social care. We've got time maybe for one quick question. That's all, I'm afraid. Would anybody like to offer? Please don't come up with opinions and so on. We haven't got time for that. If you've got a quick question, please make it quick and we will do our very best for Steve to answer it. Who would like to have a go? Go on, Anda. You are first in. It's your privilege. You need to unmute.
I couldn't wait to ask.
That's all right.
Thank you so much. It was fantastic. I love it. I was a carer, full-time carer, professional carer, care home, palliative care, domiciliary care, dementia, the whole lot. I came out last year. I went to university. I'm a full-time student in business and healthcare management. I'm interested so much in assistive technologies. So I still keep in touch with domiciliary care, with physiotherapists, all these people you talk about, and the systems. I already seen them because I worked in a call center. What happens at the other end, and I live in Surrey, my clients, they are 90 years old, don't have an alarm. I try to tell the families about all this new technology. They look at me like I'm coming from another planet. They had one of the local social care people coming and saying, oh, you need an alarm. And they were trying to sell her one of these analog ones, simple ones.
Yeah, we need to be quick here, Anda.
Yeah,
quick
so my question is, all this stuff that you tell us, physiotherapists don't have ideas, GPs don't have ideas, nurses don't have ideas, domiciliary care providers don't have ideas. How do we access the stuff you're talking about? Because it's real and I know it exists.
Yeah, exactly. It is real. It does exist. The positive to this, and you're absolutely right, there is so much technology that's out there. The positive to this is that analog to digital transition is mandated. It has to happen. So this has absolutely exploded, and we are seeing it explode. The work that we're doing in that area this year is tenfold what it was last year, which was tenfold what it was the year before. That will continue. So it will drive out in that way, happily, because there's an event which is forcing it, which is that digital switchover. Share this session with them. I'm sure John will make this available anyway on the website or something like that. So the technology is out there. we just, we need to get the voice out on it. I do agree.
All right, thank you very much. And I guess if I can try to draw this together in the short time we've got left, we've got lots of really intelligent, dedicated social care people on this call. And I suspect they're all thinking, it's all very well you talking about access, or it could be any other product and so on. How do the people on this call best instruct their ICBs in particular about what they need from their own quite selfish sometimes perspective, but it's worked experience, it's lived experience? How do these people get the message to the ICB about what they need? I would really appreciate your guidance and advice on that, because that's the missing link here.
Yes.
The ICB sit, they make the decisions, but they generally do not consult effectively with social care people. And as a result of that, too often, social care people are feeling disenfranchised from the procurement process.
Yeah, absolutely. I don't have a great answer for you other than to say we too are pushing. As I said, I wrote an article recently, it was in the Caring Times and a number of other channels, around the need to have a solid social care voice at the ICB table. It's disappointing that it is still very NHS and local gov heavy, and there's no mandate to say you've got to have a social care voice on there, because it has to be an even basis. Now, I'm sure through your various social care provider networks, through the likes of the Home Care Association, through Care UK, through organisations like ourselves, through the Care Workers Charity, we are all pushing for that increased voice, because I honestly believe that's the only way we're going to solve the problems that are out there. I don't have a great answer for you other than to tell you that we are engaged with lots and lots and lots of ICBs, as you might imagine, with the footprint that we have across the UK. And so we are pushing that message all the time as well.
Would you be generous in that case, Steve, if you're in touch with them all, if the people on this call now, and we're quite happy to act as a conduit here through the Institute, if any of you want to explain what you need, we will really happily pass that on to Steve so that he's got some evidence reference points to actually present to the ICBs, because I suspect, Steve, for you, it's difficult for you to present those real evidence-based case studies because you're not necessarily aware of the testimony from people like we've got on this call this evening. So we'd be thrilled to act for you in that regard.
And I would be absolutely delighted to receive that information. And
why don't you pop your email address up, and look, don't lose this opportunity, folks on the call. Steve's going to put his email up. You tell him what you need. Give him your worked experience. Explain to him where the pressure points are, where the interfaces fail. I'm sure, Steve, I know what you're like. You'll be very, very receptive to that.
Absolutely, yes. No, this isn't
all right. Well, look, we might have to have another session on this. We might even have to, dare I say it, bring Steve back for another session, where maybe next time you do maybe 20-minute pres, and we have a 40-minute Q&A discussion about the frustrations, I guess, of our audience, and you use that positively to assemble some case studies and some business cases to present to your ICB customers. How about that as an idea, everybody? Do we think that's a good idea?
Yeah, that would be great.
There's a lot of thumbs up for that one, Steve. We need to do that.
More than happy to. And yes, and there's a couple of people asking for further information. Just drop me a line. I'll happily point you in the right direction of things, and I will happily take any feedback you've got, any information you like feeding through, anything that strengthens our mutual case to get the right voice out there.
Well, that's what it's all about. That's what it's all about. Isn't that lovely? Well, look, I know we've gone 1 minute, in fact, in danger of 2 minutes over time. We were a bit tardy to start with at the beginning, but I do hope you've all enjoyed that. Can I just offer my thanks on behalf of the Institute to Steve. Steve, I think we're still waiting for your email address to appear in the chat.
Should have come up on the chat, isn't on there, hopefully.
Unless I'm much mistaken, let me just have
no, hang on. Sorry, Sue Jones, I accidentally just sent it to you. I must have done it.
Oh, right, okay.
So Sue's got it. Hang on a second, let me... Let me get that in there again for everybody.
Bang it to all, please. Otherwise,
Thank you,
everyone's
Steve.
going to leave feeling terribly frustrated otherwise.
Let me do
And
it.
they'll
Let's
hate
do-
you, Steve. Let us,
There we go.
Oh,
There
thank
we
you
go.
so much.
Steve.Sawyer
Thank
at
you.
There we
theaccessgroup.com. It's there. There you go, folks.
Thank you, Steve.
Lovely.
Wasn't he
Thank
good?
you very much.
Thank you.
Have a good
We'll
evening.
organise. We
And
will
you too.
organise
Have a good
another one of
evening.
these.
Bye.
We'll organise another one of these in real short order. Thanks so much,
Okay.
everybody.
Thank
Thank
you.
you so much. Have a nice
Thank you
evening.
for organizing this.
Thank
Bye.
you. Bye.
Bye bye.